Hello, I'm Nitin Sahi. I'm a neurology registrar from Royal Stoke University Hospital. So my presentation is on the clinical impact of ocrelizumab dosing delays and their association with CD19 B-cell repletion during the COVID-19 pandemic. As we all know, COVID has significantly impacted the healthcare of many people with MS. There have been significant interruptions to care with cancelled appointments, investigation, or even delays to disease-modifying therapy, of which delays to ocrelizumab have been the most common. At the start of the pandemic, the ABN recommended delaying retreatment cycles of ocrelizumab during high periods of infection. Delays were compounded by the suggestion that anti-CD20 therapies might increase the risk of hospitalization with COVID-19 and the need for intensive care, although this was not reflected in data from clinical trials and post-marketing pharmacovigilance. So if we look at the ABN guidance from May 2020, this is based on the Swedish experience of rituximab, where they found persistent disease suppression long after stopping rituximab, and given its similar effect on B-cell depletion in the long term to ocrelizumab, this suggested it may be safe to extend the dosing interval with ocrelizumab. Interestingly, they suggested monitoring CD19 B-cell repletion to a level of 1% of the lymphocyte population as a marker for which to decide when to extend the dosing interval. As a result of this, from the 15th of July, all patients with MS prescribed ocrelizumab at Royal Stoke were offered blood tests to get CD19 levels. However, because of clinic appointments being virtual and patients not wanting to attend hospital for additional blood tests, practically CD19 levels were only obtained when patients attended for their ocrelizumab infusions. We therefore wanted to identify two things. The first was whether dosing delays actually impacted on clinical relapses or radiological activity in patients with MS. And the second was to explore how CD19 repopulation reflected these dosing delays, relapses, and radiological activity. We retrospectively reviewed our electronic database of patients with MS and identified all patients on ocrelizumab who had delays to treatment during the COVID-19 pandemic. The flowchart you can see shows how we selected patients to be included. First of all, patients needed to receive at least the first full dose of ocrelizumab. That would be 2 300 milligram infusions 14 days apart. They also needed to receive the second cycle or the next cycle within the follow-up period and to have CD19 blood tests within that period. Overall, we ended up with 136 patients who were included, 71 who had delays to their treatment, and 65 who did not have any delays to their treatment. When we looked at the baseline demographics of these patients, there were no significant differences in terms of age, disease duration, gender, EDSS, or previous DMT use. The only difference we found was that in patients who had received 3 or more doses, we found no delays to treatment. On average, the delayed group received their infusion roughly 5 months later, and this was associated with higher levels of CD19 percentage. Overall, 90% of the delayed group were actually replete in terms of CD19 counts to more than 1% by the next cycle. We observed both groups for an average of 4.5 months after they received their next cycle, and despite these delays, there were no significant differences in clinical relapses or radiological activity between the delayed and the not delayed groups. Looking then at the association of CD19 percentage with dosing delays, we found that the CD19% correlated strongly with the number of days since the last ocrelizumab cycle, with a Spearman rank correlation coefficient of 0.738. This did not seem to differ depending on the number of previous infusions, although we only, as we mentioned earlier, anyone who had 3 or more infusions had no delays, so we're unable to really see if that would change. Looking at the association of CD19 percentage with disease activity, we found that CD19 levels less than 1% were not associated with any difference in radiological activity or in clinical relapses. So overall, we found a 5-month delay of the next ocrelizumab cycle did not impact on clinical relapses or radiological activity over the next 4.5 months. And this was despite significant CD19 repletion, and even though most of our patients had only received 1 or 2 previous treatment cycles. This is consistent with data from the ocrelizumab phase 2 extension trial, where annualized relapse rates and 6-month disability progression remained low during a 12 to 18-month treatment-free period after 3 to 4 treatment cycles. They only imaged a small number of patients but found no radiological activity, and they also had much fewer adverse effects and infections. In terms of the CD19 percentage levels, we found that after 11 months, 90% of patients had repopulated to 1%. In the phase 2 extension trial, it took an average, or sorry, a median of 15 months for CD19 B cells to return to baseline levels or the lower limit of normal. Our data suggests that CD19 repletion does not therefore reflect inflammatory disease activity, although it may herald a safe window to extend dosing. However, it's important to remember that early repopulation is driven by immature and immune-naive B cells from the bone marrow and does not reflect slower repopulation of memory B cells. Our study is not without limitations, and although delayed reinfusion was not associated with short-term inflammatory activity, we cannot be sure of the long-term effects. Similarly, our small sample size and relatively low relapse rates during this period limit our statistical power to detect small differences between the dosing groups. Furthermore, as clinical appointments during the pandemic were almost exclusively by telephone, we do not have data on EDSS and cannot exclude the possibility of disability progression independent of inflammatory activity. We also don't have data on the number of adverse effects, although we'd expect these to be less in the delayed group. So our real-world observations suggest a single delayed or even missed cycle of ocrelizumab is unlikely to impact on disease activity in the short term. A direct head-to-head study of extended dosing ocrelizumab versus standard dosing interval, which includes B-cell subset monitoring, would be ideal to assess the long-term efficacy, safety, and cost-effectiveness of an extended dose. One option would be to tailor treatment intervals to memory B cells, which co-express CD19 and CD27, as this has been shown to maintain reduction of disease activity in one study, and may also be more pathogenically accurate with time reinfusion intervals. So these are the references that I have acquired. Thank you very much.